Welcome, everybody. Welcome to this webinar series on improving access to quality medical care, presented by the Southwest Telehealth Resource Center and the Arizona Telemedicine Program. Welcome, especially those from Colorado, where I and the panelists are all from, and those in the states in the Southwest Telehealth Resource Center region. That would be Arizona, Utah, New Mexico, and Nevada, in addition to Colorado. So I'd like to make an acknowledgement. We respectfully acknowledge the University of Arizona is on the land and territories of indigenous peoples. Today, Arizona is home to 22 federally recognized tribes. That's a lot, with Tucson being home to the O'odham and Yaqui. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and indigenous communities through education offerings, partnerships, and community service. The Arizona Telemedicine Program and the Southwest Telehealth Resource Center welcome you to this free webinar series, and you can read the rest. A few tips and notes: when you join the webinar, your phone and/or computer microphone was muted. Please use the chat function to ask questions, and you can see the rest. This will be recorded. So, as hopefully everybody knows already, the title is of today's webinar, Challenges to Effective Telehealth in Colorado. You are going to learn from the leaders of 3 very different Colorado-based healthcare organizations, their biggest challenges in the provision of telehealth care, their efforts to address these challenges, and the degree to which these efforts have been successful or not. So, let me do some introductory stuff. Here's what led to this conversation. I've been facilitating a conversation of telehealth leaders in Colorado for a couple of years, since the beginning of COVID. We've talked about a lot of different things, but I would say in the past maybe 6 months, we've talked about what we would like to work with our legislators on to make it easier for Colorado folks to more effectively provide care by telehealth. And we've had a lot of conversations, a lot of point of views. And finally, it was Chris Earps from the Telehealth Resource Center that said, you know, let's do a webinar. Let's do a webinar and have 3 people share their views, and you're going to meet them soon. And then maybe hear from you guys, the participants, also on what are your views? Do you agree with these panelists? Do you disagree? Do you have different opinions? If you could change one thing in our legislation in Colorado to make our telehealth more effective, what would it be? So we are begging you to please, obviously you can post questions and we'll take them, but also would love your opinions throughout, and we will copy and paste them and save them so we continue this conversation. And if you would like to join the conversation of these monthly meetings with the Colorado leaders, say the word janground@gmail.com, or you can let Chris Earps know through the survey. So it was actually Chris that suggested we did this webinar. And let's see what else I want to say. So one thing I want to tell you before we go on to these panelists is in this conversation, especially through Chris Earps, we have learned that Arizona is way ahead of Colorado, and you're going to hear probably more about this from the Colorado experts. We've learned that, for example, if you are physically located in the state of Arizona, you can get care by video from physicians licensed in any state in the country permanently. And I think there might be 1 or 2 other states that meet that, but certainly not Colorado yet. So I just really want to give a big wave for Arizona. Okay, so let me briefly introduce myself and the 3 panelists, and then we will go to the questions. I am Jan Ground, and I started my career as a pediatric physical therapist and ended my full-time career 4 years ago with Kaiser Permanente, Colorado, as director of virtual care. And I will tell you that I also led innovation. And when I joined Kaiser Permanente, Colorado in 1999, they were already live with, you could email your own doctor. You could schedule telephone visits with all primary care docs and some specialists. I implemented video visits with primary care docs and all specialists. This is at least 10 years ago, as well as remote patient monitoring for diabetes and hypertension. And we also implemented chat or text with a doctor, not your own doctor. So KP's done a lot. I also want to say that my current titles are, I am the Colorado liaison to the Southwest Telehealth Resource Center, which I just love. And I am the Colorado ambassador to an online peer-reviewed journal named Telehealth and Medicine Today. It's a big shout out to SWTRC and TMT. The panelists, I'm going to tell you briefly about them, and then they can tell you more about their organizations as relevant to the conversation. Dr. John Savage is an ER doc, and he founded and leads an organization called Care on Location, which primarily provides care by video, primarily to Colorado Medicaid people, as well as people in, for example, in jails and in fire departments, for example, and other interesting, unique locations. Dr. Raj Kadari is an internal medicine doc who co-founded a group called the Summit Medical Consultants. They do in-person as well as care, in-person care as well as care by video. They have 60 combination of physicians, physician assistants, and advanced practice nurses. And their focus specifically is people in post-acute care. So for example, skilled nursing facilities, long-term care facilities, and acute rehab. Finally, and by the way, it was supposed to be Pat Kelly from Routinify, but he couldn't commit to being able to be available because he's in a very rural area that he couldn't commit would have great reception. So Raj is replacing Pat. Thank you, Raj. And finally, Gerard Frunzi is the director of virtual care for Centura Health, which is a big hospital system based in Colorado and is in one other state. And he's been there for 18 months. And before that, he was the director of virtual care for Children's Hospital Colorado. So let's go. Let's put the three panelists on the screen as well. And I'm going to ask you a question, and we're going to start with John Savage, and we will have each of the three panelists answer this question. We'll see where it goes. I can be flexible. If it doesn't go exactly the way we planned, it's absolutely fine. First question is, what are your biggest challenges in the provision of telehealth care? Go, Dr. Savage.
Hey, everybody. And yeah, thanks for having me on the panel. And thanks for the introduction, Jan, and thanks Southwest Telehealth Resource Center for having me. Just to get into what the challenges are, I think you gave a decent overview of care on location, but just a little bit more detail. So we do provide telehealth services. I've been involved since 2015 in providing telehealth care to Medicaid patients throughout Colorado. And I'm currently the chair of the Telehealth Technology Committee for the American Telemedicine Association, and heavily involved in kind of state direction on where we're going as a state here in Colorado. And so we provide care to Medicaid patients, rural patients, underserved populations in three main modalities. One, which is what Jan mentioned, which is a direct-to-patient model. And the second two are a co-location hybrid model, where we basically train and staff an EMT, a nurse, or a medical assistant in a location. As we all know, broadband is an issue throughout the state. About 1 out of 10 of families in the state still don't have access to broadband. So what we do is we set up in locations where they might be able to go, such as a fire station, a library, a community center, or other location that they can go there. We will have a trained staff member to help facilitate their care. And then the third modality is through a mobile vehicle. We have a telehealth enabled vehicle that is able to come to communities and also participate in the care. So that actually leads me to what some of our challenges are. When we have a person on scene, so let's just say it's a school nurse, let's just say it's an EMT in a community, and I'll use the CMS supported program called the ET3 program, Emergency Triage Treat and Transport Program. What that program does is it pays for an EMS agency to stay on scene and conduct a telehealth exam, but that's only a CMS supported program, and it's actually not, it's not continuing. They're not expanding the program. So it doesn't solve the problem for a lot of individuals. But what the barrier that we're dealing with in the way that we're providing care, and this would account for those organizations that are looking to expand beyond their current areas if they want to go out into the community. The reimbursement for the individual that's on the scene, the EMT or the nurse, there's a billing code called Q3014, which is the originating site fee, or some people do the facility fee. That has a very narrow scope of application, and that reimbursement component is holding back some of the expansion of care. In additionally to that, I would also say that there's some limitations on the modalities. We all know that live audio video communication is well accepted, but in our experience with rural communities or those that are, let's just say, suffering with opioid use disorder, let's expand the definition of telehealth to include other modalities. And I know there are some temporary expansions, but if a patient texts me and says, I need help, and I text back and say, don't worry, I've got you, that is a valid and clinically important encounter. And the expansion of modalities of telehealth, I think, are also one of the barriers that keep us from being able to reach more patients. The other one that I would just say is the barrier of broadband, which I think we're all well knowledgeable of. If you look at our organization's map of patients, we have patients throughout the entire state of Colorado that are seeing us, but there's a couple distinct areas of the state where there's a gap. And if you look at the Office of Broadband's map of of overlay of broadband coverage, it matches up nearly exactly with that. So continuing to push forward on expansion of broadband is another one of those barriers. I'm going to stop right there as far as the barriers that I have, because I actually would like us all to kind of talk about it, and then maybe we'll come back and talk through how we're going to address these and what we have done to address them. So I'll stop there for right now and actually pass it over to Raj.
Thank you, John. Good afternoon, everyone. Thank you for having us, especially at the last moment. My voice is a little bit affected. I've been struggling with a cold for the past few days. Hopefully my voice will hold till the end of this conversation. As Jan said, I used to be a hospitalist. I used to be the chief of hospital medicine, then started this practice 7 years back, seeing patients in post-acute purely as a SNFist provider, then expanded into the long-term care side, assisted living care side, occasional home visits, and now even in inpatient rehab, and looking to expand into the hospitalist world itself. So that's one part of the equation. So when we started our practice, initially we were looking at expanding, like utilizing televisit as a component to our practice. Unfortunately, at that time, CMS had this very strict, very narrow, limitations, specifically saying that you cannot do it in an urban area, you have to do it in a rural area, and there was very, restrictive covenants to that. So we did not expand or utilize telemedicine as an alternative for our practice initially. Obviously, once COVID hit, the facilities started panicking, everyone started panicking. There were rules and regulations being thrown around left, right, and center. Every day there was a new rule. So at that stage, we were not able to visit some of our buildings because of COVID lockdowns and all that stuff. So that's when we started exploring it. And thankfully, CMS, removed the restriction on the location for telemedicine. So that's when we could utilize the telemedicine component on our patients in the long-term care facilities, the SNFs and assisted living. So that was our first foray in telemedicine. We really loved it, but obviously being, still stuck in the traditional mindset, we still, liked going to the facilities, physically interacting with the patients and all that stuff. But our providers said that, yes, in an ideal world, they want to be in front of the patient, but in this imperfect world, they love telemedicine. So we said, okay, let's expand it more. Let's utilize it wherever we could not. So that kind of changed the paradigm of when we were utilizing the telemedicine. The other aspects of it was that as time went on, we started realizing so many of our patients were going home and then transitioning back to the hospital. So we started doing transition care management. And obviously for that, we had to utilize the telemedicine. And the challenges that we face, taking a step back, the challenges that we face in the nursing home world, obviously, is the staffing shortage, right? There's so much staffing shortage, and trying to utilize the nurses in the facility to be the other side of the televisit has always been a struggle for us, and it continues to be a struggle. But there are some buildings who have embraced it wholeheartedly, and we are getting a tremendous amount of support. Some buildings, not as much. So that's one part of our challenge. And as Dr. Savage, John said, the facility fee is helpful, but again, there's some limitations to that. So we are not able to utilize that, to provide the facilities with the option and saying that, hey, if you can provide us a staff member on the other side, probably you could get paid. We saw that it wasn't happening, and then it felt like we were, the buildings were coming back to us and getting frustrated with us. So that's one part of it, the challenge we face. The other side is the transition care management, where we see these patients within 7 days of them being discharged to their home, and where we try to mitigate the rehospitalization. We answer their questions, concerns. Home health hasn't been in their homes, so we try to kind of coordinate with our nurses to make sure the home health is following up on these patients. If there's any DME that needs to be taken care of, we are taking care of that. So those are the things. The challenges over there are obviously is a lot of our patients are elderly. They still have those non-smartphone options. So we have to depend a lot on the family members to be there at the side of the patient's bedside to kind of initiate these conversations. So that's one challenge that we are facing. Now, the next step is we are going to do is the hospital at home. That's what we are looking at. Again, as you know, the regulatory, the insurance, the patient challenges that we have to face. So we are trying to kind of take one step at a time in identifying the challenges and working with them. But we feel confident that in few years down the line, this process will be perfected, and the patients will also appreciate us being in their homes, audio visually type thing. So that I'll take a step back from this, but these are the challenges that we are facing from our side. Gerard?
Thank you. In rounding out the conversation, small correction, Gerard Frunzi. When I worked at Children's Hospital Colorado, I was manager, not director, but I am director now with virtual care. So very happy to join you all today, and thank you for the Southwest Telehealth Resource Center for hosting us. Coming from the hospital and facilities perspective, our pathway followed much of the industry, where we had a telehealth program where it worked and where it really worked beforehand. COVID came and there was a rush to telehealth, which we responded to quite well. And now we have a new normal. And what does this new normal mean? As far as the challenges that we have to deal with, it's funny because we share, as different as our organizations are, we share challenges in this room. Much like Dr. Savage, we have a broadband challenge where there are very rural patients and rural areas that patients can't get into video. However, they would really benefit from it, and how to manage that. You know, even the facilities around them. It's not like the library or the critical access hospital can easily get into a video call. Sometimes that's a significant barrier. And another one, similar to Dr. Kanari, is the people. They're busy, and telehealth has always been an optional thing. So there's been great popularity, and people see the value in it now. And it's so great to see you all joining us today with this interest. However, what does this new normal mean? Are we going to see it really shift back to in-person? And so we have a challenge to convince and to reinforce that there is great value in telehealth. And so delivering better tools and better services to continue improving, while, of course, all the other items that were called out, the reimbursement, regulatory. I did also want to include that today's conversation is more so focused on Colorado specific. We can have a whole separate conversation about the public health emergency and the extension of that. And so just to add some more content here, we'll really want to try and focus just on Colorado.
Thank you, Doctors John, Raj, and Gerard. And I'm taking myself off video for a sec because, believe it or not, I'm having broadband issues, and I want to be able to look at the chat and not have my phone turned upside down. So I really would love to see. It looks like we have 73 people, including 4 of us, on. I would love to hear, what do you guys think of what these 3 people just said? Are you having the same challenges? Do you agree with how they described it? Do you have different challenges? Obviously, you can also ask questions. One question I see from Deb O'Connor is, will the panelists be differentiating between medical and mental health rules? So why don't you guys go ahead, and do you have any comments on that? And participants, I would so love to see stuff in the chat. What are you thinking? Any comments, panelists, on that question?
State of Colorado really has brought it this past year. I think we're doing better than most as far as state laws. Admittedly, not as great as Arizona when it comes to out of state, but the behavioral health providers have been covered much better and in following with the other national trend. I'll defer to my other panelists for their insight.
Yeah, I mean, I would agree. So, I mean, if you can, Debbie, if you want to clarify, so we have provided, we provide some behavioral health services. As far as individual provision of services and the CPT codes that are covered, that part's not the problem. As far as a barrier or a challenge for us, the biggest challenge for us in that arena has been, it's really credentialing. And again, with us being focused on Medicaid, for those of you that you know, Colorado Medicaid is broken up into 7 geographic regions. Each region has essentially its own, some are combined, but it has its own management entity. And then layered on top of that is a behavioral health entity. So credentialing, if you're a medical provider and you want to be able to provide behavioral health services in some of these regions, you then have to obtain separate credentialing for your behavioral therapists or your behavioral health providers. And that can be quite a lengthy process from, you know, as short as 3 months up to a year has been my experience there. And that has been a significant challenge, you know, and so one of the action points that I would say to take is to unify some of our credentialing throughout the state and make it easier to become credentialed. If we're saying that there's a big mental health crisis in the state, then we have to take it seriously. So if you're allowing for regional provision of care, depending on who's credentialed in that region, yet there's a provider across the state that isn't, we're creating this artificial narrow network that isn't really helping our patients out. So that would be one of my action items. So yeah, again, clarifying, you know, what on your question would be Gary, but that's my take on the whole concept of behavioral health and some of the challenges right now.
So from our perspective, especially in the post-acute and in the like nursing homes and assisted living, the challenges are as what Dr. Savage has said. But on top of that, one of the things I've noticed is there's been this huge push on behavioral health from the startup community side. As a result, there's this huge sucking of all the providers onto the, this startup world where the valuations are really high. So they're able to, provide a significant amount of revenue or resources to their providers. Unfortunately, what that means is for us who are fee-for-service providers is we can't sometimes compete against the, those startups in their reimbursement model. So that's one of the challenges we are facing. Is it's a good thing that the telemedicine is, telebehavioral resources are growing up like crazy, but they are being taken over by the non-traditional practices and to the, the VC funded or the venture capital funded or PE funded entities. And then we who are in the front lines are struggling to get hire people. So it's not more towards the legislation, it's more towards the personal, but it's still a challenge for all of us, right?
And peppering in some of the other questions that we've received, and I think each of us probably has a role, and there's different, I'll pick 2 of them. What states have the toughest barriers in respect to licensure? And in my opinion, our neighbor in Kansas has some limitations specifically around medical malpractices that are done by trusts. And so a lot of academic medical centers have trusts and other organizations. And so when they want to do telehealth to Kansas, they have to get a separate policy, which is a barrier. Centura, we actually have facilities in Kansas. So we we're in there easily. But sometimes when I'm talking to a partner, that comes out. And I believe there may be one other state in the union that also has a similar law, but I'll be honest, I don't remember what it is. And I'd also like to talk about the other question I see here is about the side pact, about compacts, and is there one for physicians that allows providers in Colorado to see patients in other states? There is a physician compact. It improves the paperwork process. However, there's still a state approval process, so it's not quite as slick as SciPact, which has a telemedicine license, and not as slick as, say, the nursing compact, which is very. Every one of us are very thankful for that, to allow more nurses to be able to help us. And I'll defer to the other panelists for other questions that they see.
You know what? I'm going to jump in on that one because I have a lot of background in the interstate stuff. When we had the Interstate Special Interest Group of the American Telemedicine Association, I was very involved with that. So it's something called a compact, which is not specific to healthcare. I mean, we have compacts apparently for driver's licenses across the United States, where if you're licensed to drive in the state of New York, you are automatically allowed to drive in the state of Colorado. There are compacts also for cross-licensing with healthcare, and there's, for all of the licensed professionals, there are compacts, but different numbers of states participate in all the compacts. There's ones for doctors, there's one for nurses, there's one for dietitians, there's one for physical therapists, there's one for social workers, et cetera, et cetera, et cetera. And some have almost all the states involved, and some have very few. And as Gerard just said, for example, the RN compact, if you are licensed to practice as an RN in one state, it is very simple to be able to provide care as an RN for all the states. With doctors, it's very difficult. You have to pay money, and you have to basically get relicensed. They just accelerate the process, and the other ones are everywhere in between. So I will end that there, and let's go to the other question. A lot of questions, you guys, as you can see, panelists, are about the interstate. But let's go to the first one.
Jan, I'm sorry. I just want to just clarify that the compacts work only if you're in good standings. You have to have a current license, and in good standings. And you are right. The medical license is a expedited process. When you join the compact, you accept all of the, your state accepts all of the other states that are in the compact minimum qualifications. And so you don't have to go through that process again and again and again. But you do have to pay the processing fee to the licensing board, and you do have to pay each fee, the full license of each state. So it is a very pricey, but it is time saver for the physicians. So thank you.
Thank you, Chris. Okay, let's go to the first question that came in from Tim Rowan. I would like to hear more about home health, hospice, and home care. So I'm guessing, Raj, that you would be the best one to answer that.
This is more from the periphery because we've been doing more than the physician side, but I've been hearing a lot on the home health or the hospice side, the challenges that they are facing. Again, it's a similar type thing, right? In sense, trying to find the staff who could, communicate or connect with the patients on the other side, especially if it's an elderly patient. That's the biggest challenge they're all facing, is how do we communicate with the elderly patients on the other side? Now, especially if it's a hospice, it's even more challenging, right? They might or might not have their family members in their homes. So that's kind of the barrier. I don't know the answer to that. We are all trying to find answers to that. Hopefully someone in the panel, in the audience might also give us some suggestions where it might have worked for you guys. But we are all struggling. We are all trying to find an answer to it. Yeah, you do hear about Doximity or Teladoc or other people saying, oh, it's always easy. All we have to do is send this text. They have to click on the text and it pops up a window, and the patients and you can communicate back and forth. We did try those things. It works, but it's imperfect. That's kind of where we are.
Anybody else want to comment? Gerard or John?
Yeah, I'll just make a quick comment about, so just hospital at home, remote patient monitoring, transitional care management. So all of these modalities, in the state of Colorado in particular, remote patient monitoring is allowed, which directly ties into hospital at home type of when transitions from care facilities. It's currently in Colorado a home health benefit for the most part, particularly among HICPUFs. So it requires a direct involvement with a home health agency that can both set up the patient with the equipment and also help with any of the daily monitoring that occurs. And as Raj said, there's a medical provider side of it, which is our kind of some of our standard billing codes. And then there's the remote patient monitoring side of it, which has to do generally with the home health agency. And then there needs to be a coordination pattern between, especially if it's a hospital discharge, between the case managers that are releasing a patient to both the provider side and the home health agency side. So it just takes triangulating that communication pattern, which can be a challenge for someone we have, possibly limited existing EHRs. We have to find new patterns to make that work.
Gerard, any further comments?
Oh, not on this topic. They did well.
Okay. How about this question? I'm guessing because this came in a while ago. I'm guessing this is still related to cross-state licensing. We are definitely struggling with this. Any recommendations on where to start with credentialing? Anybody want to take that on?
Yeah, I think that was, sorry to jump, but I think that we kind of hit on some of that. I mean, the easiest way is to utilize some of the compacts. And honestly, that's what I ended up doing in the beginning. I actually started off in 2015 with some of the big national telemedicine companies. I was moonlighting on the side, and I used the compact, which has significantly expanded since 2015 to get cross-state licenses. And once you get through the system, the barriers actually drop pretty low.
And coming back to the compact is one of our physicians. He's looking to. We are expanding to North Carolina, so we were trying to have him come to Colorado to kind of learn the processes and then go back and start the workflow there. And he applied for Colorado license. At 6 in the evening? By midnight, he got the license. So yes, the compact is working. It's working really well. Only thing is it's a little bit expensive, and you need to be in good standing. That's the crucial thing, because there's another physician from Georgia who had something written up on him 30 or 40 years back, and he's struggling to get a license here. So it's been 3-6 months since we have been trying to get him a license here. So that's the challenges we're all facing. It's like it's working if everything is perfect. If it's not, that's the time lag.
So it's interesting, Raj, because I've heard good and bad about the rapidity of the compact for physicians. I've heard that it's not really fast, and you're saying it's very fast. So obviously
it could be an exception to the rule, because I was taken aback totally. It's like he said, "Oh, I got my license." I'm like, "When did you apply?" "Yesterday." "And today?" So it did happen. It does happen, I suppose. But at the same time, there's another physician we are struggling with, right? So 50-50. So.
I get it. All right, let's look at another one. Here's another one from Michael Victorov. Does putting results / notes in your portal to be read by a patient out of state constitute interstate practice? Are you practicing out of state if you engage in asynchronous e-communication? Great question.
I'm going to be bold and say that there's some gray area here. If you are providing direct patient care to a patient, you should be licensed where the patient is. You find that a lot of states have been proactive and written in some things around this. New Mexico, I believe, allows established patients up to like 10 contacts or consults with established patients without registration. But there are some gray areas. And so I highly suggest you consult with your compliance department and legal teams just to make sure that you are following your organization's needs. There's you have to recognize there's a lot of gray area when it comes to these spaces. Now, some is not gray whatsoever. However, prescribing an antibiotic when the patient's on vacation in Texas and you don't have an FDA license to prescribe in Texas, well, the pharmacist will probably still fulfill that prescription, but the letter of the law is clear. So you do have to recognize that in everything we do when it comes to virtual care. Thankfully, Colorado is pretty good.
Yeah, we have had a lot of our patients who come from out of state either had an accident, skiing, or a motor vehicle accident, ended up transitioning from the hospital to our side. We took care of them, and then they went back to their own home state. We did look back and ask our malpractice insurance, and that's one of the factors, right? And from their perspective, they were like, you could do it, but, and so there's no, black or white here. So we basically have been trying to transition them to the PCP. We communicate with the PCP on the other side and try to, close the loop. But we have not taken care of any patient. Once they change state borders, we do not take care of them anymore.
And provider consults is a wonderful way to get around that and to be very compliant, where I want to make sure you get a PCP and then you can go debrief with that PCP or that care provider. And that is a much more open conversation because you're not providing direct care. You're not billing for that care. You're just supporting that person and what they have to do.
Exactly.
Now I would add to this is based on my years again with Kaiser Permanente. So when I joined KP in 1999 and we were already doing email with your own doc and we were already doing scheduled phone visits, do you think the doctor ever asked a patient where they were physically located, ever? If they're emailing or phone? Absolutely not. And so when we went live with video visits, this is before COVID, that exact question came up. And the bottom line is the answer is no, you should not be providing care to a patient physically, no matter how you're doing it. But I know that doctors do it every day, all day. You don't ask your patients where they are when you're on the phone with them. I have a sister who gets counseling, and she goes out of town every so often and asked me, am I allowed to do a video visit if I'm on vacation in another state? And I said, legally, no, but your therapist doesn't need to know where you are. So it is very gray. John, you want to add?
Yeah, I just wanted to add. So one thing is, we all know what the rules are supposed to be. The reality is if you're a licensed provider in good standing, the compacts are trying to make it easier for us to provide care across state lines. There's actually a recently introduced federal, I think it's a Senate bill that just got introduced that actually does away with if you're licensed in a state, you're in good standing, you're able to care for patients in any state. And that harks back to my comment about kind of how our own states divided up into regions in certain circumstances. The second thing, which Gerard just hinted on, was provider to provider consult. And this is another action item that I feel that the state needs to get behind. E-consults or interprofessional consults is an area where I think the state is lagging behind even the federal government on this. Again, if we're talking about rural communities or other areas where patients can't access care, to allow a PCP to consult with a specialist through electronic means and then receive that communication back and have that specialist be incentivized to do that and provide that care to areas that can't get it, that is a key piece. Now, some payers cover that, but again, our patient population has predominantly been Medicaid, and Medicaid currently does not support e-consults.
I'm going back to the chat. I want to make sure everybody's seeing the text or the chat from Chris Earp Stewart from SWTRC, that you can get more information about the physician compact in Colorado or other states too. It says imlcc.org, and you see that in the chat. Be sure to look at that. Okay, then reading other ones. Thank you, panelists. We have had challenges with mental health across state lines for our students if they go home for break to a state that is not recognized. Absolutely, yes. Here's one from New York. I want everyone to be able to see these. In rural upstate New York, we've had the same lack of broadband and analog telephone issues. We had a successful facilitated telehealth program prior to the pandemic using specially trained EMTs. With the epidemic panic, the state adopted regulations restricting ET3 and facilitated telehealth to paramedics. Consequently, we were pushed out of the service by regulation and consolidation of medical practices that resulted in withdrawal from our rural communities. So sad. I won't say the names, I don't want anyone to get in trouble. Here's a question. Is payment parity from commercial payers a barrier? Who would like to take that on?
I've messaged with Ashley a little bit on that. Colorado does have payment parity, and Medicaid has been paying parity even before that. Colorado came out in 2017. There still are issues if the policy wasn't underwritten in Colorado and the person's employed here in Colorado. There's gaps here and there. However, I've seen when there's a gap, it tends to be with the coding because every payer wants it in their different ways. So they just reject it. So you have to go back and find out and maybe change the modifier, change this or that, and have a whole map and an algorithm on how you submit to all the different groups, in my opinion. There was a second question also about what other support patients need to use outside of broadband. Here in Colorado, I think we're fortunate that we have a pretty partnering community where facilities and other places, if you need them to host, tend to be open to host their patients, especially if it's their own. I've seen a lot of, not only just for myself, but other groups get into hub and spoke partnerships where there's a facility that'll host, maybe even in the county health office to host outside patients when there is a broadband or some kind of a problem to get to a patient's home. Including having that MA extender to kind of help to get validated biometrics. I'll defer to other kind of barriers here in Colorado outside of broadband.
All right, here's another question. As a Colorado mobile health provider, mobile, M-O-B-I-L-A, who is licensed and credentialed, how can we support you best, i.e., staff, vehicles, mobile vehicles, setting up a mobile clinic? We are currently working with the City of Denver to set up mobile health services, meeting patients where they are. Clarification, to set up mobile services, meeting the underserved and marginalized where they are. How can we support you best? Does that question make sense to you guys?
I guess I'll take that since we're providing mobile services. I'm not sure who is that question from?
That was from Elizabeth Frost.
Okay. Well, thanks, Elizabeth. Yeah, so a couple things is, finding the right locations and partners. So as we all know, again, around the state, there's several communities, several patient segments that don't have easy access to care. So finding the right communities that need it and would be able to support, I think each of us on this panel is part of a private organization. And so there's some financial issues that are involved in having a vehicle, maintaining a vehicle, having the person on there. So finding the right partnership that helps make this a sustainable model. The second would be, as a state or as an entity that provides mobile services, going back to the Q3014 code and facility fee, registering the vehicle as a mobile clinic, so that it can function with, in our situation, we perform labs, we order x-rays, follow up on all of that. So just making sure that the mobile vehicle is identified as a true clinic and not simply a marketing tool for an organization. I don't know if that answers the question, if there's a question in there, but in general, it's the right partners and the right setup and finding the right community members that could use it. So I'll leave it there.
So here's another one.
If I could continue that one for a quick moment. In Colorado and also just nationally, mobile is interesting when it comes to telehealth partnership. There's the exception for hospital at home that Dr. Kadari is looking into, and mobile is a component of that because delivering the pharmacy and other things in person. And mobile is very good even for, I imagine, a startup or people that want to take care of patients in innovative ways. There's some services that really doesn't work well on mobile, like taking a look at monoclonal antibodies in the home in response to COVID. And the number you can do in a day with mobile is very hard to put together as a business model. So I just wanted to add that little component to the conversation.
Yep, it's always a challenge trying, and in this time and age, I tell you, having the mobile component is easy. Staffing for that has been the bigger challenge. So like even within the labs and the pharmacies, the traditional pharmacies and the labs, they are struggling to find staffing for that. So it's not just the non-person entity, it is finding the person to do it too. That's been another challenge, and trying to find funding to help initiate this process. It's a chicken or egg, right? And since you need to put a lot of money in, but you're not sure whether it's going to come back and all that stuff. So you're trying to work through those edges. So one of the legislation would be is helping us create these models, and providing support to that would be a good thing from the state.
So let's do one more question from the gang in the chat, and then I'll ask you the final question that we were going to talk about of what you've tried to address these problems and what's worked. Much of the conversation has been about outpatient care. I'm guessing, Gerard, you'll be best for this one. And or Raj, because you used to do internal hospitalist care. Any experience from any of the panelists in providing telehealth within critical care ICU? Any concerns unique to that setting?
Focusing on Colorado, I don't think there's any barriers in Colorado compared to the rest of the United States. Works pretty well. The solutions that you have, the technology is so much better, and the integration between things are so much better now. Now's the time to start those programs if you haven't done it beforehand, just to leverage those benefits. Happy to talk further if anyone wants to pick brains, but since the focus today is on barriers, I don't see many personally.
Yeah.
Exactly. Yes, and we do provide a tele on-call service to one of our locations, and initially it was trying to get the physicians or the credential, because there was this thing about the geographic location within the bylaws of the hospital. Then we had to go back and communicate with the hospital and kind of get that exception to that bylaw and all that stuff. That was a bigger challenge initially, but now that the hospital has understood what it is and all that stuff, it's seamless, and it's I think everyone loves it. So more power to everyone who are doing that. Perfect.
Okay, let's go back to our questions, and I'll combine these two questions. What efforts have you made in your organizations, either the one you're on now or prior organizations, to address the challenges we've talked about? And to what degree have these efforts been successful or not? Who would like to start?
Sorry, Jan, where's this question? I kind of lost track of.
Of course. What efforts have you made to address the challenges that we've discussed, the challenges to effective telehealth? What have you tried to address these challenges? And have they worked or not? We learn from failures as well as successes. Do you want to start, Raj?
Sure. So one of the challenge, obviously, is what we are realizing is when we do the transition care model, right, is trying to make sure the patients on the other side are able to access the phones, access the tele component. One of the things we are looking is to hiring EMTs for our own practice who can go into the patient's home and be the person on the other end with our own iPad and all that stuff. Two advantages. One is obviously we are able to communicate with the patients and take care of it. But the other thing, what we are realizing is by being in the patient's homes, we are able to assess their living, the lifestyle, their issues that they are facing, and also the medication reconciliation, and help them guide through that. So that way, their transition is much more successful when they do go home. So that's one part of it that we are looking at for sure.
I'll go next, if that's all right.
Yes,
as far as response to the broadband issue and the participation issue, we're constantly focusing on our products to make it easier for providers to engage in our platform. As a department, that's just what we're doing, what we're focusing on to try and make things better for patients and spread the word, spread the good news. For broadband, there's a lot of things coming up, and I would encourage you all in Colorado to keep an ear out for the things that are coming up, panels and committees and offerings for broadband grants. If you are in a low bandwidth area, there's gonna be opportunities to apply for funds, and you can do it in partnership with schools and hospitals and partnerships with counties. I mean, the county can put in these applications to try and get more fiber, more things laid. There's a lot of federal dollars that are on their way in the next year and a half. So that's our focus. The solution right now is training and orienting and doing advanced troubleshooting if you can, a lot of logistical work to deal with the broadband issue. I'll defer to John.
As far as what we've been doing, I mean, I personally have been involved, as I mentioned earlier, on the, as much as possible on the national level through the American Telemedicine Association. But here in the state, the state has, as Gerard hinted at, several different, there's committees and working groups. And I was participating in the telehealth and broadband working group. And now the state of Colorado has fairly frequent telehealth stakeholder meetings. And what they saw again was that big spike in telehealth use across the state during the pandemic. That obviously caught a lot of people's eye from both a financial and what does this mean for health across the state. And so moving forward, just for those that know, those that provide telehealth only are considered e-health entities, and there's a bunch of stakeholder meetings going forward. And so I can share the information I have about that for those that are interested in participating in the telehealth stakeholder meetings moving forward.
One quick point is what we are noticing is, yes, there's a broadband component of it. The other part of it is the Wi-Fi component of it too. Is in some of the facilities in the rural areas, the broadband might be there. They might be paying a lot of money, but the weakest link could be the Wi-Fi itself, where we are trying to communicate through the nurses to the patients and the signal keeps on dropping. So we are trying to look at having those jetpacks and all that stuff, but at the same time, it's still since there are multiple components. Yes, what's the word? The last mile, right? Yes, you could provide the broadband to them, but if they don't have the sufficiently updated software or the Wi-Fi or the modem, that's also a challenge. So we need to look at it in a 360 view in that regards too.
We're just looking to see if there's any other questions. And while I'm looking to see if there's any other questions, as I said, I'd love to hear from at least 5 participants on, do you agree that the problems that these panelists have spoken about are our biggest problems? Do you think we've missed anything? Do you have different opinions? I would love to hear from at least 5 people while I'm looking to see if there's any more questions. I'll give you extra credit. And panelists, if you see any questions I've missed or is there anything else you want to talk about, go for it.
Yeah, I mean, I
No,
I was just going to say, as far as involvement on what, what I think we need to get to, and I mentioned the stakeholder meetings, is a lot of us are trying on our own. And, this is kind of my kumbaya moment. A lot of us are trying on our own to engage and do the right thing by patients. And it's through these various stakeholder meetings that collectively we can help make effective changes. And I'll just give a quick plug to the Colorado Health Institute, has published some really good documents about telehealth in the state. They had a recent one on telehealth strategies and how we should approach it. And they use a mnemonic called RAPID, which is reimbursement, access to services, providers, information for patients and providers, and then telehealth definitions. So just using a combined strategy on how we want to approach this for our patients. And, all of those that are in the panel or on the panel and in the chat, seeing each of you again in some of these, statewide meetings would be good.
One thing I'll tell you this is pre-COVID, I wasn't pretty optimistic about tele and the future, but with COVID, I'm very bullish about, the implementation of tele, not just from the patient's perspective, from the legislator's perspective. There's been a huge change in their mindset. Everyone, like with CMS or with the state legislators, there was always this, so what, or why do we need this, or is it going to be beneficial, or what are the loopholes, this, that, and all that stuff. With COVID, there's been a sea change. Everyone's kind of looking forward thinking about it. So I think I'm more optimistic, and we need to keep on, picking up the momentum and pushing and pushing and pushing. As a group, individually, whatever we can do, let's keep on pushing it, please.
Agreed completely. And the way we do this is to work together more. I mean, there's people online thinking about ideas, send emails, make partnerships, you know, make connections, so you can take care of patients better. There was a question about documentation issues, liability coverage, and patient expectations. It's a good call out that there are particulars around telemedicine, standards of documentation you have to make sure you keep in. And sometimes that's picking the brain of someone that knows a little bit more. The Telehealth Resource Center is a great place to go. There's Southwest one covers the states here, and then there's some national ones. So I'd encourage you to get involved and partner with groups like that.
So speaking of email, we're running out of time here. Chris, can you please share the email, because they've all give permission. Can you please share the emails of the 3 panelists as well as my email with the whole group?
One thing I want to say is Tim Rowan has a great point. I have to admit, I'm concerned about the effort of hospitals and physicians to find ways to get people into homes without considering the 125 years of experience of home health nurses and home care aides. That's a wonderful point. I totally agree with you. We should be doing this. It's just that, again, as Gerard and John have been saying this, it's like we all have been trying to do it in our own lanes. But I think this is a wonderful thing that Kristen and Jan have brought in together so that we all could share these ideas and we could basically continue this conversation after and try to, work together with each other so that this will be a success.
Yeah. I wanted to clarify my point is that, I mean, it's not to allow someone in my role to do more of what Dr. Kadari, Dr. Savage is doing. This is for us to partner together so that when that home health person is there, it should be a standard of care for primary care and specialty care physicians to all connect with that primary, if there is a nurse in the room, to coordinate care and to make things better, blur the lines between our organizations so we can partner easier.
John, any final comments? Dr. John?
No, I mean, I just, as we come to the, I guess, bottom of the hour, no, thanks for having me. And I really appreciate being part of this panel.
So I want to remind everyone that, again, the reason this webinar came to be is because Chris Earps with SWTRC recommended we do this. It's a random group of people, meet monthly to talk about what's going on in telehealth in Colorado. If anybody would like to join us, it's open to anybody. You don't even have to be in Colorado, but it's definitely about Colorado. We would love to have, if you join us, you can email me, janground@gmail.com. Chris will share that. And Chris, I think it's time to show the closing slides. Oh, goodness, okay. Okay, so check our websites for upcoming webinars, www.telemedicine.arizona. And your opinion is valuable to us. Please fill out the survey. Everybody who knows me knows that I love feedback. Anything we could do to make this better and more valuable, better use of your time, I'd love to hear it. Thank you, everybody. Good luck with telehealth and join the group if you can.